Good afternoon, dear colleagues. The COVID-19 pandemic has confronted us with many challenges. Even more than ever, primary care professionals worked in the front line, risking their own health and protecting those of their patients and communities, especially the most vulnerable. However, this pandemic provides us also with opportunities. It can even be a game changer to strengthen primary care as a strong, person-centered, population-oriented primary health care has proved to be most effective in combating this pandemic. We, my colleague Andrea Canini and I, hope to show you today how maintaining our core values is possible even under difficult circumstances, and how our experiences as primary care professionals during this pandemic could help to reinforce primary health care in all our countries. I am Maria van der Muijsenbergh, a family doctor in the Netherlands and a professor of health disparities and person-centered integrated primary care, as well as a member of the executive board of the European Forum for Primary Care. In our presentations, we will focus on the impact of the pandemic on our most vulnerable populations and the experiences of family doctors caring for them. We will show that a strong primary care collaboration leads to better outcomes of COVID-19 infection and plead that we can turn this pandemic into a game changer for stronger primary healthcare systems. After my lecture, Andrea Canini will tell about his experiences in caring for the homeless population in Bologna in Italy as a practical example on how to deliver person-centered integrated primary care to vulnerable groups. Worldwide, the COVID-19 pandemic has shed light on the pervasive impacts of social and structural inequities in society. COVID-19 is having a disproportionate impact on people who are already disadvantaged by virtue of their race and ethnicity, age, health status, income, residence, or occupation, as you can see in these pictures. In all these groups, we notice a higher infection rate as well as a higher number of persons being severely ill. The reasons for these are multiple. Higher exposure is due to less opportunities to work at home and less protection in risky professions like the slaughter company you see a picture of, and crowded houses, especially migrant workers often sleep with 3 or 4 people in one room if people have any housing at all. And poor people, socially disadvantaged people, have to rely on public transport as they often don't have their own transport. As a result of existing socio-economic inequalities, these people already suffer from higher levels of chronic stress, and these have led to more chronic diseases like diabetes, cardiovascular diseases, and all of which we know now are risk factors for worse outcomes in case of COVID-19 infection. So they get more easily infected. If they get infected, they are prone to be more severely ill. And on top of that, many people suffer from limited health literacy due to language barriers, low educational level, or learning difficulties. As a result, official information about the pandemic and confinement measures often was too difficult for many people to understand, leading these people to rely on social media information and thus increasing the risk of misinformation. For them, also the remote ways of consultations, like video consultations and e-health, to which most practices had to turn to at the start of the pandemic, are much more difficult to follow. And they often even refrain from consulting their doctors altogether. This and already existing barriers in accessing healthcare for socially vulnerable groups like financial barriers, language barriers, cultural differences, etc., added to patients' delay and postponed care. And not only are these groups at higher risk of COVID-19 infection, they are also more prone to suffer from what we call the collateral damage, economic and social damage caused by the pandemic and its preventive measures. Many low-paid jobs are or will be lost over the coming months due to the lockdown, leading to more poverty worldwide. The closing of schools increases the educational gaps, as many low-income households lack the facilities for home teaching, and many low-educated parents don't feel up to the task to provide their children with the necessary support to do their homework. This all leads to more fear, stress, and loneliness in these vulnerable populations, as we know from several studies in the Netherlands as well as in other countries. And on top of that, they more often than other people suffer from the adverse effects of postponed healthcare and other service. As I told before, they often have difficulty assessing the healthcare, and they often are afraid to access healthcare, and the same is for other services as social support, financial support, etc. So this is a clear example of the socio-economic health disparities, which means each step lower on the social ladder, people get more chronic diseases and are prone to an earlier untimely death. And we know also that migration is an independent extra risk factor to this, as we also have seen abundantly clear in this COVID-19 infection. And this means that especially in times like this, we have to ensure that all our patients receive the care they need. Thus, we have to strive for equity of care. In the near future, this will primarily concern to make sure that all vulnerable groups have access to the COVID-19 vaccination. And let us, the workers in the front line, be advocates for this equity and make sure they get what they need also with the vaccination. We did a lot of studies in France, Belgium, the Netherlands, other countries, among family doctors caring for persons in deprived areas. And we know that also these family doctors noticed the adverse effects of the pandemic on their socially vulnerable patients. Especially in these groups, initially, at the start of the pandemic, chronic care was disrupted, as patients didn't show up and primary care practice didn't have the time to reach out to them, and people didn't want to have online consultations. Doctors noticed also that assessment by telephone and the lack of non-verbal communication cues was especially challenging in these patients, who have often difficulty expressing their complaints due to a lack of common language or limited health literacy. Doctors even noticed serious errors made in the assessments, leading in 1 or 2 occasions to more severe disease in the patient. And in general, these family doctors were experiencing that teleconsultations were not feasible in many deprived areas. People lacked the equipment to carry out a good consultation. They lacked the money to call by phone or whatever means, and they didn't rely on it so easily. On top of that, doctors were also confronted with patients infected with COVID-19 whose housing was not adequate for isolation due to too many occupants or to the fact that they lacked any stable housing at all. And they noticed, as a result of all these challenges, a sharp rise in stress, fear, and depressions among these groups, even more than in other patient groups. So there were a lot of challenges, especially in realizing good care for vulnerable populations. But at the same time, primary healthcare workers, family doctors all over in the front line showed that adhering to our core values of family medicine, the core values of primary care, resulted in rapid and effective response to the pandemic, especially in those vulnerable groups. Primary care professionals guaranteed person-centered comprehensive care for all their patients after a very short time of getting adjusted to the new ways of working by reaching out to their vulnerable populations, often in collaboration with their local governments to realize care and isolation facilities for the poor and homeless. Where necessary, they provided understandable information about the infection and preventive measures, often in different languages, as they noticed that their migrant populations were not informed well about the governmental policies. And after initial challenges, primary healthcare workers rapidly reorganized their practices to ensure continuity of care. And in all this, the importance of integration of medical care with public health and with social service proved to be vital. There, where already strong collaboration existed, this was achieved faster and easier. So this was one of the lessons for the future. Let's integrate our systems of care and know the people we want to work with. And so, COVID-19, although challenging, appeared to become a showcase for strong, integrated, community-oriented primary health care. As always, the family doctors were there for their patients from the start by assessing, testing, treating, or guiding in isolation until the very end, providing palliative care for the many people dying at home from COVID-19. And doing this, we showed that regions like the province of Veneto in Italy, with a strong primary healthcare system that has ties with the local community and is collaborating well with public health, proved the result in far better outcomes of infection rates and hospital admissions than regions that were more hospital care focused, like the province of Lombardy, also in northern Italy. And I now want to go a little bit brief into these two regions because it makes so very clear why a strong primary healthcare system is important. Because although both situated in heavily affected northern Italy, there was a striking difference between the region Veneto compared to Lombardia. The cumulative rate of infections was 2.3 times higher in Lombardy, and the cumulative death rate even 7.5 times higher in Lombardy than in Veneto. In Veneto, on the other hand, there were twice as many people per 1,000 tested. This could be explained by the focus in Veneto on primary health care instead on hospital care, as was the case in Lombardy. Primary health care in Veneto already had a strong informatic network, so they knew immediately of any positive tests and could start tracing, testing, and follow-up. Primary care epidemiologists worked together with public health to trace and test. They had a daily telephone contact with each person in isolation, and a mobile team consisting of a family physician and public health staff made home visits for evaluation. People were only hospitalized if they required oxygen or otherwise were seriously deteriorated. And you can see here that the number of persons in home isolation in Veneto was much higher than in Lombardy. 72% of all patients stayed at home in Veneto compared to 48% in Lombardy. Equally, you can see that the number of people admitted to the hospital in Veneto was much lower than in Lombardy, 23% compared to 47%. And you could also see that the number of deaths among patients was significantly lower in Veneto, as was the number of affected healthcare workers. You see here in red the number of healthcare workers infected with COVID-19 in Lombardy, over 6,000, compared to a tenth of that amount, more than 600 in Veneto. And in Lombardy, there were regrettably 17 family doctors died from COVID-19 infection and none in Veneto. So this example shows the importance of a strong population-oriented primary healthcare system. Primary care remains the cornerstone of pandemic response and has shown itself to be highly adaptable in meeting the unique demands of the pandemic. Primary care needs to be resourced, of course, with sufficient equipment, training, and financing. And thus, this pandemic can act as a game changer to achieve the necessary adaptations in systems. This requires serious investment of governments in primary healthcare, as the 30 by 230 campaign is striving for. I will explain that a little bit later. We also need new organizational and financial models, as well as investments in the workforce. I would call all of you to support the 30 by 2030 campaign. This is a campaign for investing in primary care. To prevent most diseases and treat people in a holistic way, community-based primary healthcare systems need to be strengthened. And therefore, organizations like our own WONCA and European Forum for Primary Care have launched this 30 by 2030 campaign. These organizations call for international donors to assign 30% of their vertical top-down disease-oriented budgets to strengthen integrated horizontal community-based primary care systems by 2030. As the outcomes of person-centered population-oriented care are much better in way of less hospital admittances, more cost effectiveness, and better health outcomes than those of disease-oriented approach, this has to appeal to everybody who wants to improve the health of the whole population. This is not the only thing we need. As shown before, we need also an integration of primary care with public health and social care, because only then we can address the needs of the whole population and their health needs related to social problems. This means the organization of more interprofessional collaboration, as well as appropriate financial systems to enable and stimulate interprofessional collaboration and assure that social causes for health problems can be addressed in the system. And of course, these changes ask also something from us, the primary care professionals. In addition to person-centeredness, we have to acquire a population-oriented perspective, which would be enhanced by the training of primary care epidemiologists who provides us with the relevant information on health and well-being, including the social determinants of health of our communities and practice populations. We, doctors, nurses, social workers, physiotherapists, midwives, ergotherapists, etc., we all have to be trained and facilitated in collaborating with each other and with informal carers. Community health workers are very important to reach out to deprived populations and link them to healthcare and social services. And even more important is it to empower the local population and support them to being able to take care of their own health and lives. In the end, this kind of person-centered, population-oriented primary care will help to achieve that every person in our communities receives the care and services he or she needs in order to fulfill her own potential. Thus, then we will achieve equity of care. Now, my colleague, Andrea Canini, will show a marvelous example of his work in the homeless population of Bologna. Thank you for listening, And I hope to see you in person next year at Wonka Amsterdam and at the EFPC conference in Bergen, Norway. Goodbye.
Good morning, everyone, and thank you for being here. My name is Andrea Canini, and I am a family doctor working in Bologna, Italy, and an executive board member of the European Forum for Primary Care. In my speech, I will introduce to you the work that I have been doing since the beginning of the pandemic in the two main shelters for homeless people in the city of Bologna. These two shelters are called Rostom and Beltrame, and they host respectively 40 and 120 people. And their main characteristic, if compared to other public shelters displaced over the city, is that they are suited to host marginalized people with moderate to severe health conditions. In fact, most of them are affected by chronic or acute conditions, and some of them are admitted in these two shelters through a project called Dimissioni Protette, or Safe Discharge in English, a project that was started 5 years ago with the aim to provide a safe post-acute care environment to homeless people after hospital discharge. The project can offer a prolonged stay at the shelter for many different conditions, ranging from acute orthopedic problems, tuberculosis, mental health problems, substance abuse, diabetes, just to name the commonest condition found between our group of people. These two shelters are daily visited by a group of nurses and once a week by a family doctor, that's me, and by two psychiatrists. We work in close collaboration with the professional educators running the structures, and every 2 weeks we meet in a multi-professional meeting to discuss single cases. After this quick general overview on the functioning of these two dorms, let me introduce to you the work conducted to tackle Covid-19 pandemic in these two dorms for marginalized people. As you might know, it was the 20th of February when the young anesthetist Annalisa Malara diagnosed the first Italian and the first European case of Covid-19 in the small city of Codogno. After that, fears and preoccupations started spreading around the population and even more notably among marginalized community. There is this sad thing I noticed between marginalized groups that when times get hard for everyone, those who are left at the margin feel the urge to claim and to make their voices even louder because of a legitimate fear of being the first to be left behind. This can be considered as an effect of marginalization and rising inequality itself in our society, and as health professionals, we had the responsibility to hear and to respond to that claim. There are two key concepts that led our work during this pandemic. The first one is for sure advocacy. Advocacy is still a neglected concept, both in medical education and in medical professionalism in general. In my opinion, advocacy could be defined as the capacity of moving extra steps beyond traditional core activities. In times of health system crisis, when even for the general population accessing services can become a burden, this becomes an essential capacity of health professionals. So activities like booking exam for your patient, accompanying a patient to see a specialist, or taking care that they have access to a proper diet can become a routine activity when both health and social services start to creak under the pandemic pressure. This is also guaranteeing the right to health. Since the first pandemic outbreak, we have mounting evidence of the disproportionate effects and consequences of COVID-19 on poor population, both in terms of incidence and mortality. Housing problems are still one of the main drivers of the disease, especially where a proper quarantine cannot be guaranteed because of lack of spaces. Essential under this regard was our close collaboration with the Public Health Department. Despite some difficulties at the beginning to get our concerns heard, we spot a light on the situation of public shelters, and we managed together to improve our response to COVID-19. After a few weeks, we were provided with PPE so that we never had to quit our work that was kept in presence and not by remote during this whole period. Still, during the first pandemic wave, if we had a suspect case of COVID-19 in the shelter, we necessarily had to refer the patient to the hospital both for testing and for proper isolation. That wasn't clearly possible inside the shelter itself. Not an ideal solution indeed. But during the summertime, the management of suspect and confirmed cases inside public shelters definitely improved through the connection with COVID-19 hotels that you can see in this picture. Today, whenever there is a suspect case of COVID-19, both me or the nurses can safely perform a nasopharyngeal swab at the shelter and then immediately refer the case to the COVID-19 hotel. There, the patient will await for the result, being safely isolated from the community in a warm and decent place. The therapeutic continuity is safeguarded through the collaboration with the nursing team of the hotel, even for complex therapies like methadone, and I can keep visiting my patients in a safer environment. This connection was guaranteed by the public health department and definitely improved the management of suspect cases without putting further pressure on the emergency department. The second key aspect and a core value of primary health care during this pandemic regards presence and continuity. Since the very beginning of the pandemic, every effort was done by the medical team in order to keep regular work in presence and not by remote inside these two shelters. During the first outbreak, educational activities on COVID-19 and how to prevent it were done in collaboration with professional educators. The hosts were instructed on the use of masks and how to perform hand hygiene and other measures. The compliance to these measures is variable, but in general good. From March on, in these two structures, we had only 2 confirmed cases, which were all rapidly isolated and no cluster until today. After the finding of a positive case, all contacts were tested. 3 weeks ago, we also started the flu and anti-pneumococcal vaccination campaign with an overall good adherence. For the very first year, the vaccination campaign was performed directly inside the shelter and covered also pneumococcus, a major health concern in this group of people. This is just to mention that hard times can also lead to new and positive outcomes when different actors are prone to face new challenges together. Let me just conclude with a quite paradigmatic case, the case of Elizabeth. Elizabeth is just an invented name. Elizabeth is suffering of chronic alcoholism since many years, and after March, also because of a family-related problem and a feeling of loneliness exacerbated by the pandemic, she started suffering of depression and increased her alcohol intake. On a sunny day of July, she got drunk and fell asleep on a public bench and got a serious sunstroke. She was then admitted to the hospital because of a low-grade fever, disorientation, and agitation. She was timely tested for SARS-CoV-2, which resulted negative, and stayed for a week in the hospital for antibiotic treatment and other supportive treatments. When she came to me, I noticed the bad condition of her hands that you can see in the picture and of her skin in general, with a very peculiar distribution of a skin rash on the sun-exposed part, in particular hands and arm bilaterally, which reminded me of some pictures seen in medical texts some time ago. She was later on tested for vitamin B3 deficiency, which confirmed the initial suspect of pellagra, a rare disease in rich countries, but still not so rare in people with chronic alcohol disorders or in situation of marginalization. Even in times of COVID-19 pandemic, diseases of poverty and marginality are there and will become even more frequent in the near future. We must stand close to our communities and empower our interprofessional collaboration to respond both to the present and the future challenges taken by COVID-19. Thank you very much for watching, and bye.
So, thank you so much for this wonderful journey. You have covered between you two all aspects, from the bigger health systems and health policy to the very rooted in the vulnerable groups. So if we can choose the whole discussion set, we are getting questions already. So maybe I will start with some initials until more questions come. And I would like to start with Maria. Thank you so much for sharing your thoughts and making the case for the game changer. This is our keynote on experience with the COVID pandemic, and you are clearly making a case for how these health systems can be made stronger. And Andrea has wonderfully presented on a specific project that does these things. And I must I had to think on the primary healthcare Alma Ata declaration, the values, the multidisciplinary team, providing the services on the time people need, where they are, and this wonderful thing. So my first question to Maria would be, do you see, because you were saying about the vulnerability, do you see a change in what vulnerability means because of the COVID pandemic? And the second question close to that, so that you get two on the road while more people are coming, is what barriers do you see? Because you were saying that the patients will refrain maybe from visiting healthcare, but do you also see from the health systems a barrier maybe in the getting the appointments, or that it is too much focus on the COVID situation?
Yes, well, thank you for these questions. To start with your question on vulnerability, it's indeed interesting that we see some changes in the traditional vulnerability for diseases. Well, to start first with, what not changed is that poor people, people of ethnic minority background, are likely to suffer the worst from this infection, as I have discussed before in my lecture. However, what is different is that we see now that especially older people, and already starting above 40, are much more vulnerable, also when they don't have much comorbidity. And very interesting that females are less vulnerable. And that's in contrast to many other diseases where also women are more likely to be vulnerable. However, what perhaps the gender-related issues make them less vulnerable is balanced in a negative way by the fact that females all around the world are more likely to live in poverty and socially vulnerable circumstances than men. So that makes it also for them a hard thing. Another group that is more vulnerable in this infectious disease than for other diseases is, of course, the group of professionals working in healthcare. There we see relatively many infections. To your second question about the barriers in the system, well, certainly at the start of the pandemic, we have seen so much focus on hospital care, highly technical care in intensive care units, etc. Understandable, because there was a need for that. But we saw, at least in many countries like the Netherlands, that it was causing a lack of anticipation and of care in the long-term care facilities and primary care. So in primary care, and especially in the long-term care for older people, we lacked all the protective equipment. We were not informed and not included in the testing. So there were many challenges, and that, of course, meant that at the start of the pandemic, people were much more prone to end up in hospital, also when perhaps that would not have been needed. I think that during this second wave, at least in the Netherlands, we have changed this for the better, although still we see a focus, what we are used to, a focus disease-oriented, highly technical-oriented, hospital-oriented. And I think it's understandable because of the severe illness and the pressure that consists on our system, but it is very important to include in all this also the social aspects, the psychological aspects, and the need for care close to homes and from out the really values we all share, that it's important to be cared for by the whole family and the whole community.
Wonderful, thank you so much. This brings me now to short questions to Andrea. and the questions are starting to be piled up on the chat questions, so you can have a look also at them. And I also had this question that the first participant is asking. So Andrea, you were showing this, what Maria is saying, a connection between social work, I think, for a specific group in the population. And the question is, how do you get that funded, and how do you get that financed, and how do you send the informations to make this a big game changer, as we are seeing it is coming in the questions?
Okay, so to come to the first question, the project Di Missione Protette, Safe Discharge in English, is funded by the Department of Primary Care. So, and there is also the municipality of Bologna, which is historically a region with strong social and primary care services, is funding this project. So this is just to briefly answer the question. I just think that it's important to think on the last image that Maria showed in the presentation, the classical picture with the three different men of different height trying to look to the game. Of course, if we think that we want to guarantee the access of vulnerable population to primary care, maybe just giving them a personal GP, as it happens for the whole population, cannot be sufficient. I see every day that most of my patients at the public shelter have problems in assessing their GPs because of many different reasons, which go from personal reason to organizational reasons. So the idea of having an extra GP who is also bridging with the GP of the user, I think it's quite good, because it's actually providing that extra that is needed to overcome barriers and to actually guarantee the right to health that otherwise would be hard to achieve. So.
Very nice. Thank you so much. I would like to ask Professor Frese to select some questions and maybe state it also.
There was one question coming in from Muijsenbergh asking, what could GPs do to be the game to be changed?
I think one of the things GPs just could do in their own community is, well, several things. First, to align with their social care providers and with public health to make sure that they work together and know of each other. Another thing they can do, and I think that is also referring to the question of Amanda, how we can be careful that the information about a vulnerable group doesn't split society and politically division, that GPs can show their community that all poor or disadvantaged people are in there together, and they can also support each other. So I think reaching out proactively to your population and to your patients and explaining why certain groups are more vulnerable and what they can do about it themselves would be a good start. As well would be the advocacy to your local government, like for instance was a very nice example in France, in the region of Pantin, in northern France, that they aligned with their local government to make sure there was isolation for the poor, facilities, there were food programs, etc. So I think you are an important person as a GP in your community, and people rely on you. So make use of that position and reach out to the community at one hand and to the local politicians at the other hand.
Very nice. Thank you. Both. We are having a lot of questions and we might not have time to answer all of them, but mainly thank you for your presentations. There are two questions. One is about the strategic plan for primary care, and it is related also to the last questions. How do you ensure that whatever interventions you are planning or informing are uptaken by those that need it? So mainly many questions are going into that aspect of reforming health systems and what to do. So what would be your proposal to that? For example, are places with strong primary care, this is another question, have been performing better than places or regions without primary care? How do you tune the services offered in primary services with the community needs and assessment? And are there differences, for example, in the GPs from Veneto and Lombardy that you were reporting?
Yes. Yes, there are indeed, and the cases of Lombardy and Veneto are quite paradigmatic. Lombardy is a region that politically, in the last decade, took a path of strong privatization and a strong hospitality-centered approach, which might be also good for very specific disease. But in general, when we talk about primary care, this approach has shown, especially in these last months of epidemic, all these frailties and all these problems. While Veneto region, on the opposite side, in the last decade, undertook a process of strong reliance on territorial services, both for social care and for medical care, which proved to be very, very powerful and very effective in tackling the pandemic, especially through the test strategy, which was fueled by Professor Crisanti, which was the main informer of the Veneto region. So this was definitely something important for that area of Italy to have a reduced number of cases. And I would say, in my opinion, that essential and key for success is the interaction between primary care services and public health services. As I said, for the very first year, this year, we managed to provide directly inside the shelter uh, flu vaccines and anti-pneumococcal vaccines. That is something that was never done before. And this was possible thanks to the strict collaboration between primary care and public health services, which was for sure fueled by the COVID-19 pandemic.
Thank you so much. And we have almost reached the time. First, please leave the whole people together on the screen. Thank you. And there is one question. We should apparently learn how to adapt more to the health systems and to the population-oriented approach. In my personal opinion, considering the whole system, the best part of it that has resiliently adapted has been primary care. So I think everyone deserves an applause in this Wonka and European Forum and GPs round, because I don't know the studies have been made, but I'm sure the resilience in primary care, and Maria, you were making the point, GPs have adapted rapidly. We were stroke, got it, and immediately back on the spot. So I think those examples were fantastic. We have very interesting questions also from Amanda Howe saying, how can we go beyond the connection? How can we increase collaboration? And I think there are questions on the chat. Please make a copy of that. Think about those and about these examples. It has been a wonderful session. I think we are reaching our time. So keep up the good work. Thumbs up for primary care and all GPs. Let's connect and work together. I think that's the beauty of it. Between us, among us, across us, there is no country is big enough. So let's make it as one in the world. Thank you so much for being here and joining, and hope to see you around in person soon.
Thank you all.
Bye.
Bye. Thank you very much.